Well, for those of you who don't know me, my name is Jody Palaha, and I am one of the co-editors of the journal Family Systems and Health, and also have been very involved in sort of regrouping the Research and Evaluation Committee with CFHA in the past several months. And one of the things that we're interested in doing this year, up until probably through the summer at least, is holding monthly webinars where we learn about a research topic, but also we discuss how CFHA can facilitate bringing that research topic, the skills, the knowledge, the coordination, connection, and other infrastructure around that research topic to membership. So what we're going to do today is have some really amazing speakers talk to us about health policy research, particularly as it pertains to workforce development and behavioral health. And that'll be a really interesting research topic. I'm really excited about it. This is a topic that's new for me, and I've been very eager to learn about it. So I'm glad to see that quite a few of you are also eager. We'll spend, 30 or maybe a little more minutes learning about that from these two speakers. And then we'll have time for you to ask questions about it, just like you would in any talk. And then in the last 10 or 15 minutes, depending on how things go, we'll spend a little bit of time just brainstorming this material and thinking, how would membership like to learn about this, or how could they gain from this information? And what are some other ways that CFHA could bring this information to membership? So as you know, we have two great speakers here today, both of them from the University of North Carolina, Chapel Hill. One is Dr. Lombardi, who is the director of the UNC Behavioral Health Workforce Research Center and deputy director of the Carolina Health Workforce Research Center, both of which are HRSA-funded national workforce centers. Dr. Lombardi is an assistant professor in the Department of Family Medicine and a research assistant professor at the School of Social Work at the University of North Carolina at Chapel Hill. She previously was at the University of Pittsburgh. Hey, I didn't know that. I'm a Pitt alum myself. So very cool. And then we have Dr. Desak Zerdin, who currently serves as the deputy director for the UNC Behavioral Health Workforce Research Center, and then is an associate professor at the University of, there's a little piece missing in your intro bio. Is it social work?
At the School of Social Work, yes.
School of Social Work at the University of North Carolina at Chapel Hill. She serves in the School of Social Work's Director for Interprofessional Education and Practice over the last 7 years, and has served as the Senior Associate Dean at the School of Social Work. So some really great background and experience. I met these two at CFHA in the fall and just knew right away what a great fit they would be for our organization, and what a unique set of interests and skills and sort of a burgeoning area of interest that they could bring to us. So without further ado, I turn it over to them to tell us what they know.
Thank you, Jody. Let me share my screen. Can everyone see that all right? Can't see your faces. Is that good?
Yep, we can see it great.
Thank you. Thank you, Jody, and thank you to everyone who has signed on today. We know that your time is incredibly valuable and there is so much information out there. So we appreciate you spending an hour with us today. As Jody mentioned, my colleague Brianna and I are going to talk to you today about some research projects and interests that we have been engaged in, which are really perplexing because they take the practice realities and they think about the policy regulations. And as social work practitioners and as social work trained researchers, we have to be pragmatic and think about what that means and what do we learn and do with this evidence. So we are really excited to be here today. Let me share my screen. Just to kind of give you a brief overview so you know where our talk is going. You heard brief introductions from about Brianna and I, and we're happy to tell you more and answer questions. So please, of course, put those in the chat, and we'll try and move quickly to get through to the question part at the end. We want to talk to you about workforce research, not only that this is a federal priority, but really what this means for behavioral health, what it means for CFHA membership, and how happy we are as two individuals who have found CFHA. We have heard about it for many years, and this past conference was our first time attending, and we both just were so giddy with excitement that we had sort of found our people who understand how all of these pieces fit together to provide more comprehensive care. We'll tell you about our new workforce initiative and what we have in store for the next 5 years, and give you some examples of the policy related research that we have engaged in, and then want to talk to you all about how your expertise and practice might align with the future work that we do with our center. So as you all know, the behavioral health needs of the United States have really been at a flashpoint, and you can't really turn on any sort of news media, social media, any sort of conversation without hearing about the behavioral health and mental health crisis. When I say behavioral health, obviously we're talking about mental health conditions and substance use conditions simultaneously. But it's really impossible to ignore that people are really starting to pay attention to behavioral health. We know that we had some traction with this when integrated care started to become more prominent. We started to think, oh, behavioral health impacts health. And now we're recognizing behavioral health is health. It is what our country is grappling with. And from cradle to grave, we know that behavioral health is a huge concern. You see it in the day-to-day in your practice realities, but you, yourself, your families, we know that this is a very dire situation with what we're having to deal with and the resources being finite. We want to point out to you that despite this inundation of information, the COVID-19 has really put a spotlight on the behavioral health needs of the United States. And so we have a couple of graphs and graphics for you to just kind of take this all in. It is something that you already know, but just stopping and thinking about the magnitude of what we're talking about, it is really unbelievable. So when you look at the spikes that have that the pandemic has exacerbated, you see that for two very common conditions, anxiety and depression, you see the baseline is the dotted yellow line to the image with the colors. And if we had symptoms of anxiety at 8.1%, we see at the height of the pandemic, they jumped to 36.9%. Depressive symptoms went up fivefold, and then symptoms of anxiety and depression together, we see went up to 42% from 10.8%. And this is just in a matter of a few, a year or two difference. So it really has caught the attention of policymakers, of researchers, and of providers. And we know that for overdose deaths, there has been some really catastrophic circumstances with COVID. The isolation, the fact that people were maybe not able to get their medication-assisted treatment. It was just a very lonely and isolating time. And we see that with the number of fatalities related to drug overdose deaths. Just, I think 2 days ago, the CDC released some new information from the Youth Risk Behavior Survey that really stopped to look at what this means, the behavioral health crisis means for our young adults. And really in a 10-year span, you can see that for young females, rates of sadness and hopelessness went from 36 to 57% for female identified young folks, and 21 to 29% in 10 years. And so just imagine that increase, that percentage increase for every year, and just how catastrophic that can be. And then the same is true for suicide attempts. We see that it was worse over 10 years for almost every racial and ethnic group except for Asian and multiracial students. But we're talking about suicide. And so even just one of these percentages is clearly too catastrophic. And then same with mental health services. I know this graph might be a little bit hard to see, but you can see from 2008 all the way to 2020, you have rates that have increased in every different age group. So again, this cradle to grave phenomenon that is happening, and then needing to have a workforce who knows how to work across the life course, across family and developmental milestones, and just really how pervasive this is. So with all this in mind, I think it's really important to consider that the thing we want to do is we want to create more behavioral health workers. We want to find and produce people who are going to meet the need. And that certainly is part of the picture, but it is not the only picture. And I think it's very easy for people on the periphery to think that adding more workers to address these needs is what's going to dig us out of this hole. And we are here to tell you that it is so much more nuanced than that.
Thanks, Lisa. Yeah, definitely. And as behavioral health clinicians, we saw this tsunami coming, and this is due to a chronic underinvestment into our behavioral health care systems. And these situations are now at the forefront, and excitedly folks want to address them. But as Lisa mentioned, the situation is complex. And so I sit in many meetings. For example, today I'm down at North Carolina NCD-HHS looking at a workforce strategic meeting. And what is the common policy solution for the crisis we have to behavioral health service access? Always, it's just if we had more people, we would solve the problem. If we had more clinicians. So next slide. So, and we do have this workforce and behavioral health service delivery are intricately tied. About a third of Americans are living in behavioral health shortage areas, and increasing access to behavioral health care requires an adequate workforce, an adequately trained workforce, but it's more complex than just more clinicians. Next slide. So Lisa and I, while we've been trying to dig into how do we explain this? How do we say it's more than just more people? And we have used Pachansky and Thomas's access to healthcare services framework that was developed in the late 1970s to really tease apart the facts that there are many dimensions of access. Availability, that is demand compared to supply. So the overall shortage of behavioral health providers is one component to difficulty accessing healthcare services. But there are other components like accessibility or the geographic relationship between services and the people, and certainly looking at a distribution of those few short supply behavioral health workers. Accommodation, access, or the navigation of the behavioral health system is notoriously complex, and folks don't know how to enter into the behavioral health system. And acceptability, because continued perception of behavioral health services, continued stigma and bias towards folks who receive and access behavioral health services, as well as increasing the diversity of the behavioral health workforce that reflects the folks that are accessing those services. And then finally, and probably maybe most importantly for North Carolina, as we are looking to possibly expand Medicaid, is affordability or the cost of care. And cost of care, we know, is the strongest predictor of likelihood of behavioral health treatment. So really, we show this to say that there are more than just availability, supply, that there are multiple components and multiple policies, next slide, that we can address. So it's not, we don't have just one policy lever. That is educational training grants or loan repayment grants, which are commonly used and are great. And we don't want to decrease those, but those are just one of the multiple policy strategies that we can use, or the levers that we have to increase the behavioral health workforce and distribute them. And some of these are more service delivery lines, like telebehavioral health or integrating behavioral health into community health centers, primary care, and schools in order to increasing accessibility. Thinking about care coordination and service referral lines so folks can enter the behavioral health system. Integrating health settings into trusted delivery sites, increasing the peer workforce, and of course, payment policy and mental health insurance, making sure we are aligned with mental health insurance parity. And so, some of those aren't traditionally what we think of as a workforce lever, but they are factors that impact the workforce, how people are positioned, where they're able to provide care. And so these are just a few of the multiple interacting and compounding factors that connect workforce policy to access to behavioral health services. And, folks don't always understand the intricacies of behavioral health clinicians, how we are trained and educated. Our scopes of practice are different across multiple states. Our licensure and certifications are different, and those are also intricately tied to payment and reimbursement. And all of these are different policies that could be considered when thinking about expanding access to behavioral health care. Next slide. So that's kind of where we sit. I'm sorry, I thought I turned off my Teams, but it's alerting me, even though it's closed. So that's really where Lisa and I sit is, we come to workforce research from wanting to understand how integrated behavioral health was going to change social work practice and how social work practice could fill in that area. That's truly where Lisa and I started maybe 7-8 years ago. And what we have seen and expanded is that we look at what are the barriers to practice and service and education that impact workforce, and vice versa. What are the workforce policy regulations that keep folks from accessing care? And so we kind of come at this from two sides of the same coin. And we also want to really consider the local, state, and federal policies. So, behavioral health care is, now with tele does not have to be delivered locally, but on average care is delivered locally, but it's intricately tied to state and federal policies. And so that's kind of where our policy lens sits, is really, looking at different models of behavioral health care and say, why aren't folks accessing it? What are the workforce policies that are driving this? And what options do we have in order to address it? Next slide.
So we're going to talk to you about some prior work and then some work that is underway. And this is where we're going to start. It's one of an earlier studies that we have done. It has been published. So if you'd like to learn more, we can share the link later. But wanted to give you just an example to put all of this together. So some of you on the call may be familiar with what is called the BWET mechanism, the Behavioral Health Workforce Education and Training Mechanism. I know Jody is a PI for one of these projects, and some of you might be involved in the training as well. But the purpose of the BWET mechanism, it's a terrible acronym, but the BWET mechanism was started in 2014, and it came out of the Obama Now is the Time initiative, and it was an initiative in response to Sandy Hook. And it, I really don't share that lightly, because I just know that we passed the 5-year mark of our Parkland shooting. So to think that we are still dealing with these issues, which are finally causing us to think about behavioral health, is really, it's quite tragic. But that's where this funding came from. We saw that people were having mental health crises and acting out in really dangerous ways. And so they wanted to make sure that there was a behavioral health workforce to address this. The original mechanism focused only on social work, but then the 2017 grant mechanism focused on other types of behavioral health providers. It could have included psychologists, psychiatry, nurse practitioners. And so for the study that we're going to talk about, we only looked at the social work programs. But I wanted to just clarify that there were other types. There were a few other types of behavioral health programs which were funded. So this mechanism in 2017 funded 59 MSW programs across 33 states. And the idea was that if you can expand the behavioral health workforce, we wouldn't have young people who are in crisis situations and doing things that are going to harm themselves or others. And so we were so happy to be an original grantee of this funding mechanism. But it was incredibly frustrating because we were in North Carolina and we were a state that was not moving towards integrated care in a swift way. We were not even discussing Medicaid expansion, although just yesterday it passed our House. So we might be one of the late adopters. So that's an exciting policy breaking news alert here. But it just seemed like such a disconnect. I have, millions of dollars going into these programs to train a workforce to enter a state that isn't ready for them. And so this seemed like such a misalignment. And so we decided to do a mapping analysis to see of the schools who got the BWET funding, where are they in terms of states that have expanded Medicaid? So I wanted to show you that alignment. And before I show you the map, I will point out that because this map and this paper was, it's fairly dated, it's going to look slightly different now, but not dramatically. So if your state is colored in a different way, we are well aware that other states have since adopted Medicaid expansion. So when you look at this map, it's from our paper, but we wanted to just show the states that had expanded Medicaid versus the number of funded BWET social work programs. So I'm going to tell you, just to kind of orient you to this map, the black solid shading, those are states that have no Medicaid expansion and no BWET mechanism. So in some ways, that's like kind of a good use of funds because you're not you're not expanding into a workforce that then doesn't have jobs. So there was alignment there, however poor it is, because obviously even in states that don't have the funding and even states that don't have Medicaid, they probably have very high needs. But at least there was alignment. The light gray states had the BWET mechanism, but no Medicaid expansion. And that is where North Carolina fits in. So just to orient you, we were a state that was one of the most well-funded states for BWET. We had 5 programs of social work receive this funding in our state, which didn't then have future jobs for them. So that is obviously an example of really poor alignment. The light shaded states were the majority. There were 64.7% were in this like misaligned category. The dark gray were expansion states, but no BWET. So here you had a state that really wanted to ramp up the services, but no training program to get workers there. And then the white states had both. So there was better alignment, the exact opposite of those black shaded states. So here you can just see that, you know, for California, such a large state, they only had two behavioral health workforce training programs working to work in this arena. So we wanted to just highlight that there was substantial and there continues to be substantial misalignment. And as Brianna was saying, we are not suggesting that a disinvestment in training and education programs is the answer. We are just saying that in some ways the right hand doesn't know what the left hand is doing. And so you're pumping out workers to be prepared for practice realities that don't exist, or they can't utilize their expertise and training. Another barrier related to some of the policies is when these graduates leave the field, they graduate and they enter the field, they're not yet licensed. And so there's a lag time before they actually are hired in and can work as, you know, functional, reimbursable behavioral health clinicians. And so that's a real misalignment with the millions and billions of dollars that have gone into this specific workforce training initiative. So when we think about this, and going back to our Pachansky and Thomas model, you know, we're talking about availability. That's a really important element of these policies. But really thinking about accessibility and where are we able to access care and who is there to provide the services, but also affordability because of Medicaid expansion and how critical that is for the people who are most vulnerable and in need of behavioral health and healthcare services. So that's just one example.
Another project that on its face might not look like a workforce policy study was looking at how, in particularly federally qualified health centers, are using the collaborative care management and behavioral health integration codes that are available at the Medicare level, and for some states at the Medicaid level. And so, you know, we know that the uptake of COCM and BHI is slow and the underuse is well documented. And we were really interested in not just asking, like, are you deploying these codes, but like, what's keeping you from being paid for the services you might be delivering? You all are, this is the call. This is why we love CFHA. We don't have to explain what COCM is. But, you know, in our mixed method study of 10 states, we had about 46 survey respondents of FQH administrators describe if they use the COCM codes and the BHI codes. And, you know, 13% and 17% of the folks that we were surveying were using those codes. Concerningly is that there was even a lack of awareness. So those that were not using those codes, we asked them, well, were you aware of these codes? And the majority of them were not even aware of the availability of some of these codes. So again, this, you know, major federal initiative to get COCM to be one of the CPT codes available for Medicare beneficiaries. Many states have expanded to include Medicaid as part of their service and not being delivered. Next slide. But when we really talked to it, so we did mixed methods where after we surveyed them, we asked if folks wanted to talk with us. We asked them what was keeping it. And there was a lot of workforce implementation issues that were driving the lack of use of these codes, the lack of reimbursement. Simply, folks said COCM is difficult to implement, and it's not even just the payment. And so that, you know, again, this mismatch of having payment models that aren't matching the practice realities of many of these settings. And other folks told us that COCM is not sustainable. It became a cost benefit analysis of if they brought enough money in these 15-minute chunks that would be able to pay for their behavioral health clinicians' time. And the reason why it was not paying for the behavioral health clinicians' time is that those behavioral health clinicians were still expected to provide those 45-minute psychotherapy codes, which means that they needed to be licensed to bill those codes, which includes licensed clinical social workers and licensed clinical psychologists, which have a higher payment than maybe what the model intends to be at a behavioral health care manager level. And so FQHCs, we're trying to deliver this integrated behavioral health collaborative care management, but also needing to pay for their clinicians' time. And so they found other ways to fund their time. So, for example, this person said, again, with costs involved, we can't just set a therapist up or a social worker upstairs in an office and wait for the possibility that maybe somebody might want us to come in. So kind of, again, this mismatch between, needing to be a licensed clinician in order to reimburse for your 45-minute, which is paying for it at the same time as wanting this federal initiative to be reimbursed for COCM. Next slide.
So some of the previous work that we have done and the study that Brianna just mentioned was funded by the Behavioral Health Workforce Research Center, which used to be at the University of Michigan. And then the University of Michigan had some leadership changes, and it created the opportunity for us to apply to be the larger center. And so we did, and we got it, which was really incredible. We had appreciated being the PIs and being funded to do one project, but now we were really going to be in charge of all of the projects and finding partners that would work across behavioral health provider types and settings. So we were just awarded this a few months ago, which was really, really just such an exciting professional win. It was just really so amazing. And what this is a 5-year cooperative agreement funded jointly from HRSA and SAMHSA. So we'll talk about some of the other workforce centers, which are primarily HRSA, but we have SAMHSA support, which is really appropriate given that we are also dealing with substance use. And we are responsible for producing at least 8 policy relevant behavioral health projects a year. So 8 of the types of projects we just described throughout the year. We are not the PIs on all of them, but for this first year, we are involved in most of them. And it's a really great opportunity to have the voice of federal officers at SAMHSA and HRSA to talk to them about workforce issues, to find out what their priorities are and how we can produce evidence that is going to help them figure out where the next training should be aligned, what states are needing reimbursement mechanisms to help address some of the needs. And so Brianna and I don't do strict policy analysis, but we provide the evidence for policymakers and federal organizations to be able to look and understand what it means to be part of this workforce, what it means to be part of this service delivery model.
As Lisa mentioned, there are 9 or many other federally funded health workforce research centers, and this funding mechanism has been in existence for about 11 years now. So many of these centers have been funded for the past 10 to 11 years to do, as Lisa said, these 1-year policy relevant research projects for different workforces like allied health or oral health, long-term care facilities. And there are 2 that are considered emerging topics. And so these are kind of what are the health workforce needs on the horizon. One of them being the Carolina Health Workforce Research Center, which is our sister center and the one that I'm the deputy director of. And that is where the integrated behavioral health work started 8 years ago, was that emerging topic center. Really saying, integrated behavioral health, integrated healthcare is moving. What is the workforce needed to deliver those models and team-based models? And so that's really how our work started, was through that. But we also put this out there because all of these do, 4 to 8 projects a year as well, and they might have policy relevant work that is related to your area if you want to check out these different groups. And the Health Workforce Technical Assistance Center puts out webinars and data, state level data on different health workforces if you're interested in learning more about them as well. Next slide.
So our priority aims and areas as a study, the driving aim is to really improve behavioral health and well-being of the United States by strengthening the current and future workforce. And so we do this through 3 primary ways. The first is to evaluate disparities in behavioral health occupations to reduce behavioral health disparities. Who's going into certain professions? What is their loan debt ratio? How much years of residency or training are required? Do they reflect diverse groups in the United States by gender, by culture, by language, by ethnicity. The second priority area is to investigate workforce composition and data needs. It's really frustrating in the behavioral health world to quantify our behavioral health workforce, because as Brianna will show you in our next slide, it is so diverse. If you're counting surgeons, you can kind of put them in a neat box and count pediatric surgeons, for example, or you can count cardiologists. But for a behavioral health workforce, it's much more fluid. You could be talking with folks with lived experience who are peers. You could be talking with LMFTs or nurse practitioners, counselors. It is just so much more diverse. And so coming up with those large data sets to really hone in is really quite complicated. And then we also want to assess service delivery methods. So not just type of modality, who is doing it, but also setting and space where this is occurring. And one thing I didn't say about our center is that we are really excited to work across those different behavioral health professions and not be guild specific, which is something we have learned from CFHA, but really also thinking about having a consumer voice, people who are consumers of behavioral health and their caregivers. And so we'll talk about a project that is aiming at that. And then we also have organizational advisory members. And I really was remiss in not mentioning that Neftali Serrano is on our advisory board. And so we are really grateful that CFHA is one of our advisory board members for this initial kickoff year. And so when we have findings or we have questions, we can go back to our advisory board. We meet with them quarterly and can kind of just give them some information and ask if this is making sense or what is their interpretation of what we're seeing or why this may be. And so we're really excited to have kind of that whole breadth of consumers all the way to kind of experts working in organizations such as yours.
And I'll just quickly talk about the behavioral health workforce composition and why, it's important to have a center that focuses specifically about the behavioral health. I'm sure you all are on conversations. I'm on so many conversations where we're talking about the behavioral health workforce, we're talking about it. And then I realize they're just talking about psychiatrists. And, the psychiatrists are a very important component of behavioral health, but it is just one small profession across many others. And so really we speak to that, again, there are many behavioral health professions that have roles that are needed to address this monumental crisis that's occurring. And, behavioral health is unique to other health workforces because we work across different settings. We work in health settings, we work in community settings, we work in home settings, we work in schools. Now we work via telebehavioral health. And so our workforce is broad, but most of the data focuses on siloed professions that are not, and so we can't understand kind of the total portfolio of behavioral health providers in one area. And again, behavioral health workforce spans sectors, while most administrative data is reduced to one setting. So again, we might know deep about one setting, but we're blind to the multiple settings. And then we don't have data or an understanding about the unlicensed and paraprofessionals who are immensely important to this field because they're not typically tracked through licensure or graduation data. And so, part of, I feel like Lisa and I just starting this is just highlighting these issues with data and finding ways that we can improve behavioral health workforce when we're thinking inclusively about all the different professions that might be filling a role.
So when I'm finished presenting in the chat, I will go ahead and send just our landing page. We're developing a website right now, but it gives just a little bit more detail about this year's project priorities. And so when we wrote the grant, we had to say to HRSA and SAMHSA what it is we would look into. Two of our projects this year focus on peers, really trying to understand what keeps peers in the field and to retain them into those types of positions, and what could organizations do to make sure that they are retaining the peer workforce, for example, or looking at the adequacy of their training based on the core competencies for peers. We have another project that is looking at behavioral health screening uptake, who is doing them, where is this occurring? We have another project that is looking at the harm reduction workforce. So for folks who are involved in community-based harm reduction services, what are they experiencing? What are the gaps and the holes in the work that they do? What are their needs? And so we can think about that. We have several others. Brianna is going to just talk to you about one, which is a little bit further along, looking at areas of disadvantage based on an index that she'll explain in just a minute. But you can see here, we were supposed to have 8 projects. They wanted us to do 10. They liked our ideas. But you can see again the gamut of who we are looking at, focusing from peers all the way to psychiatry and community-based, all the way to hospital or inpatient settings as well.
Yeah, I think they liked our ideas, but I also think this shows the federal interest in workforce. As one of my mentors who's done workforce research for the last 30 years, she's like, wow, it's so hot right now. It hasn't always been this hot. We're lucky that it is, of interest right now. But I think that also speaks to the federal government just, being a fire hose of wanting to understand what's going on. So again, I'll talk to you about one project briefly so we can get to questions. That we really wanted to look at the maldistribution of behavioral health providers, particularly 3 behavioral health professions that are not always considered, and that is clinical psychologists, clinical social workers, and counselors. Usually these professions are identified in silos, and we were interested in looking at them together as well as separately. And so when we think about the maldistribution, commonly you'll hear about the rurality as an issue for behavioral health workforce access, and certainly that is. But we were also interested in looking at this intersection of rurality and need, community need. And so particularly during COVID, you may have heard about these different indices that measure area disadvantage. And these indices compile multiple indicators to identify the disadvantage or the need. And the one that we're going to use for this, or the one that we have used for this study, is called the Area Deprivation Index, which was originally developed by her son, is now housed at the University of Wisconsin Neighborhood Atlas project. And they rank neighborhoods by socioeconomic disadvantage from 0 to 100 at the block group level, which is a pretty small. A lot of our workforce data does it at the county level, but if you all live in a county like I do, part of it is Chapel Hill and part of it is more rural North Carolina. And those folks have very different access to behavioral health services depending on where they sit. Next slide. So we were interested in looking at a data source that includes these 3 different, and so we used the National Plan and Provider Enumeration System. This is managed by CMS. This is just one behavioral health workforce data source. There are many others. Clinical psychologists, y'all have a lot better licensure data than other folks do. But we were interested in finding one data source where we could find multiple behavioral health providers in it, and this is the one that we selected. And within MPPS, they get providers include their practice address. So we geocode their practice addresses and place them within a block group. You can see in our total, this was data pulled from, I think, late fall 2021, was about 840,000 behavioral health clinicians, the majority of those being counselors, and then split between social workers and psychologists. Next slide. So again, that ADI, or Area Deprivation Index, is a scale from 0 to 100 that we deciled, where 100 or 10 is the highest level of need. So communities with the highest level of need. And we evaluated the per capita per 100,000 people of the number of behavioral health clinicians per 100,000 people in those block groups with those different ADIs. And as you can see, if you're in communities with the lowest level of need, you have a higher proportion of behavioral health providers to your population. We do have this swoop, interestingly, where at the 10, or those in the highest need, have just as many behavioral health providers per 100,000 as those in that ADI level of 2. But next slide. When you lift the hood, you see significant variations by behavioral health provider type, and I'm sorry that these are small. So MFTs are not included in this, but we would love to do another study including MFTs. We have, you can see on the left is social workers, on the right is psychologists, and that there is differences based on provider type of the proportion per 100,000. Next slide. And really, it's counselors that are taking care of or are placed in the tail end of higher need areas. So we broke apart counselors because in MPPS, they lump counselors together, but these are very different people. Some are licensed mental health counselors, those are on the right, as well as addiction counselors versus maybe an undergraduate level counselor position. Next slide. And then again, there is an intersection between rurality and ADI, and that settings that are rural are less likely or have a lower proportion per capita than urban settings. But there is interesting trends that are differences across the both. So Lisa will take us off, but obviously this is just one example of highlighting the maldistribution and where it intersects with workforce, with behavioral health workforce.
And we're talking about very specific behavioral health workforce issues, but really, if you want to take a very macro lens, like this speaks to just policy issues and inequities in our society generally, right? So you can think about, if you're looking at neighborhood ADI, that has a lot to say about housing stability, SES, where transportation is located, school quality. All of those things have an impact on where workers choose to live, and if they're part of the community, they live outside of the community. So when we talk about policy, we are not even beginning to talk about some of those structural policies, which have an impact on everything we've talked about. So we're at the end, towards the end of our presentation, but we just have one or two more slides to really say, so like, what does this mean and how do we convey this back to our funders? The first thing is that we have to have monthly calls with HRSA and SAMHSA where we give them updates on our projects, and they might have questions, they might share new information or news that they have coming down their pike. We are also responsible for being on call to their questions. So at any point this year, we can anticipate these rapid responses where they can pose questions to us, and we have 10 days to provide them with a policy sufficient, well-informed response. And that's just to be available. So when there's a behavioral health issue or need, they have people to call on and look into that. Our projects have several deliverables. The first is a policy brief, a 2-page brief or a longer brief, and we can share some of those examples. We've been, really wanting to get this out into the literature because we think it's really important that we contribute to the literature and talk about all of these issues and elevate the work that you all do in the settings in which you work. Presenting at a conference like CFHA in Boise was a really rich experience, and continuing to do that across sectors, and then through other state and national meetings, panels like Brianna being at the state level right now. And so really, before we end, we just wanted to just highlight that there are so many wonderful ways to collaborate. The first is through pilot money and being the PI for a project. So if there is an idea that you may have, which has just been really burning you up and you really wanted to look into it, the center does offer smallish, anywhere from 30 to 50K awards to do a relevant related project, the things we're describing. There's 3 different phases, and we're at the mercy of the federal government and their funding. But the first phase would happen later in spring, where we would elicit 2 or 3 sentence ideas, very simple. And if HRSA likes that, then they will come back and ask for a 2-page overview of that idea, with the expectation that it would begin in September and it would end the last day of August. So it's a very rapid cycle, which is actually really great because it forces you to get the information up and out. Perhaps you don't want to take on a project of your own, but you might have a really good idea, or you might be seeing a trend that is really perplexing you. You can share that with us, and we can find researchers who might be able to pull that together and have you be involved as a collaborator or a co-investigator. And then we also are, using CFHA to talk about priority areas and talk about ways that our policy has, that our research has relevance to policy and to service provision. So we really value that advisory capacity, and that's a way that we hope will continue to remain connected. So that is our presentation. I know that there are some questions and thoughts you all want to get through, but we really welcome your feedback and thoughts. We are new to running the center, and we really are excited to see where it goes. We value what you have to say. And if you'd like to contact us, I can put this in the chat as well, but just wanted you to have our contact information. So if this gets your wheels turning and you want to follow up, we would love to hear from you after the presentation. And I'll go ahead and stop the share for now.
Yeah.
Thank you so much.
Lisa will put in the chat, and I know Jody we've had conversation with Jody about how to encourage this collaboration with CFHA more broadly, or REC. And our time, because like Lisa mentioned, we are at the mercy of the federal government. Our timelines for this call request could come any way from March 15th to June 15th. And so we will give you all warning, but if you are interested, you have ideas for a pilot project, please reach out to Lisa or I, and we are happy to just chat with you in advance. And we'll stay connected with Jody in order to make sure that CFHA records or larger groups have opportunities to apply for this pilot money. Thanks.
That was a wonderful presentation. I appreciate it so much. And I had a few people even sending me private messages to say how much they were appreciating the information and getting something out of this. And I want to encourage people on the call to use those email addresses if you have questions about the studies that were presented today, specifically about workforce or any of the sort of broad topics. I'm wondering if people on the call would be willing to talk about, ask questions, or just generally discuss their interest in, we've got a question that fits right with what I was going to say. The misalignment data and what you see as policy solutions. So interpretation of one of the studies. Is that what the question is, Gretchen?
Yeah, I was just kind of curious about the kind of potential uses of that data and what the vision is for that.
Sure, that sounds great. And we'll take a couple of those types of questions, and I want to shift over to sort of how can CFHA help grow capacity to do this type of research. So go ahead and answer that question first, though.
Sure. Gretchen, I can send you the paper too, because it'll be more eloquent. But just thinking about several things, funding emerging professionals is really exciting, but then really thinking about advancing mechanisms so that you support folks 2 or 3 years post-graduation so that they are continuing their education. Unfortunately, we have a very bottom-up approach to expanding the workforce and building up the workforce, but really it needs to be top down and bottom up simultaneously. So we made some recommendations for where you could intervene in the training and supervision of those workers, and then really ultimately just how important Medicaid expansion is and kind of advocating for that. But we can share more on the paper if you'd like.
I'm curious if there are people on the call today who feel they would be interested in doing this type of research, whether it's under one of these funded mechanisms or just doing workforce policy oriented research. Is anybody on the call inspired to do that or already doing that, or any of the above?
I definitely am. I'm been specifically around access for LGBTQ populations, maybe specifically in rural or states where policy does not always support access to care. And so, yeah, that would be my, I guess, more niche area, but definitely looking at workforce availability with that in those areas.
That's great. And Maggie, where are you at?
I'm at UT Southwestern in the Department of Family and Community Medicine
Wonderful.
element team. So yes.
Great to have you. Anyone else? Anyone else interested in doing this research?
This is Emma from the Farley Health Policy Center at University of Colorado.
Hey, Emma.
Hi, thank you so much for this presentation. It's really great to see where the Workforce Center landed and kind of seeing what you all are up to. Our center focuses a lot on behavioral health and primary care integration. And we work primarily at the state level and we've done some kind of single state behavioral health workforce analysis in Oregon. We have a project underway that we're planning for here in Colorado. And so I'm curious to hear a little bit about the scope of the pilot projects that you're interested in. Are you interested in kind of state to state comparisons or more so just national studies?
Thank you for mentioning that. And yeah, I love the work that y'all do. And HRSA is interested in national policy, but we have advocated that it can be difficult at times to do meaningful work at the national level, that it takes observing maybe 3 to 4 states and really kind of digging our hands into those and understanding more. And so certainly on average, HRSA is interested in national work, but so much of state workforce planning happens at the state level, and policies that can occur. It's a really important avenue. And so that is not exclusive, but yeah, I think for us, we've been able to pitch projects where we have looked maybe at California and North Carolina and Michigan as a way to show some geography variations, but also maybe policy variations. And that has been of interest to HRSA. Yeah, thank you for bringing that up.
Yeah, the single state studies are probably less of interest, but if you can even find just a few comparative states, then that seems to be fine and allows people to still do what they want to do, thinking about their state implications.
Thanks for that response. It's helpful to hear. And it also sounds like mixed methods are appropriate.
Yes,
they've been pushing quant, but as we just talked about the limitations of behavioral health workforce data, we talk about mixed. I think that's been and we have done qualitative studies in the past as well. And so, as always, the research question drives the method, but just advocating to HRSA why the data is not available in maybe a national way, that we need to collect primary data through mixed methods or other ways.
Thanks so much.
Great questions. Seems like we have about 3 people on the call who are positioned to do this type of research either now or in the near future, maybe 4 or 5 even. Are there people on the call who would really love to keep up with this type of research, even if not creating new knowledge, at least kind of keeping up with what this research is finding, because you are doing some advocacy or policy work in your state, and knowing the results of these studies would help you advocate in some way? It's true for me. Anyone else?
I think definitely kind of a related question is also, somebody had mentioned like a specific clinical population, and I was wondering if maybe policy or advocacy efforts towards specific clinical populations and expanding access for them, like so I'm moving into a researcher position that's focused on perinatal mental health, which is kind of a hot topic right now in mental health. So just kind of curious about like those specific, you talked about like state versus national level, but also we could talk about like topics like that.
Yeah, we are.
Yeah, one of our projects this year is on peri-mental health. And I know Brianna has worked in this field as well. No,
I mean, and for us, we're just trying to tip the iceberg of like, who is the behavioral health workforce that is working in perinatal mental health? And we're coming at it from claims data. So it's national in scope because we're using a very large private insured population to look at if you're a person who is pregnant and you receive a mental health service, where is it delivered? Is it delivered within a community-based mental health agency? Is it delivered in an OBGYN or other healthcare setting? As just like the tip of the iceberg. But yes, I love the idea of thinking about clinical populations. I think that's really important, and something that HRSA is really interested in. So your topic area is of interest to HRSA, definitely.
Are there other comments, observations, or just thoughts as we get to the end of the hour? I'll just say what comes up for me is future presentations on very much like this one, I think, with just awareness raising around the value of research that results in specific policy recommendations and implications. And then secondarily, communicating to people about how your center can help them get started on projects, get funded on projects, get some technical assistance on projects, but also communication of the results of your projects that may have applicability in policy and advocacy conversations all around the country. And I see that Lucy's hand is raised.
Yes, as a Spanish speaker provider here in South Carolina, there's so limited resources. In my organization, I work for NFUHC, Cooperative Health, and I'm the only one. And it has been a really challenging, I'm sorry, I didn't notice my camera was off. And it has been a real challenge of finding somebody because I am the director and the division director, but at the same time, I keep my caseload because there's nobody else to provide services. So making and including those type of research in our presentations and in advocacy programs to incentivize colleges or even minority groups to be participants in this work. So just having those numbers is good, but also having the demographics of those professionals also is helpful to show where we need to work and where we need to focus to include the diversity in our profession.
Mm-hmm.
And I'm a licensed professional counselor, by the way.
Really important point.
Yeah, thank you for that, Lucy. And we would love to continue on to do that work. And concerningly, in North Carolina, maybe other conservative states, we're actually asking fewer people about race, ethnicity versus understanding. And so really wanting to we're not trying to gather this information to be voyeuristic. We're gathering this information to ensure that the population that is being served is reflective of the population that we're training for behavioral health. And yeah, we should talk. We haven't done anything on like Spanish speaking providers, behavioral health, but I think that's a really, if people are interested in that area, that would be an area that we would be interested in talking with you all about, because I think that's a huge area that we haven't touched yet.
I want to be respectful of everyone's time. We're just about at the hour. Aubrey, was there anything you wanted to add or say at the closing?
No, I guess just if anybody has additional feedback about if this is a topic that you'd like further programming on, or wanted to offer some brainstorming suggestions in terms of additional content that we could offer either at the annual conference or through another webinar like this, or some type of enduring content we could post to the CFHA page, reach out. I think we have all of your emails, folks who have registered for this call, so we might reach out with follow-up questions to get your input.
This was an excellent presentation.
Yes, thanks, Astrid. And thanks everyone for joining the call today, especially our speakers. You all are knocking it out of the park. And I learned a lot, and I loved even just the basic conceptualization of workforce and policy levers, just really organizing frameworks and really instrumental work. And so thank you for that. And thanks everyone. And we'll keep looking in your emails from the listserv for our monthly series. We'll look forward to seeing you next month.
Next month, you will send out.
Yep, it'll come through the CFHA listserv.
Okay.
Bye, everybody.
Thank you.